Right, okay. Good evening, everybody, and welcome to another BSIR Industries-sponsored webinar. This is the second webinar we've had sponsored by Penumbra, and it's titled Efficient and Targeted Vessel Sacrifice with Coil Technology. And this evening I've got two excellent speakers who are going to talk through some of the uses of this embolization technology. We're going to start with Raghu Lakshminarayan, otherwise known as Raghu, because it's easier to say, and then we're going to move on to Andrew Christie. We're going to do both of their talks, and then we're going to take discussion and questions and answers. Well, hopefully some answers after the questions at the end of this. So those of you who don't know Raghu, Raghu is a consultant vascular radiologist at Hull Royal Infirmary. I've known Raghu for quite a few years. I didn't know him when he was in Australia. He claims he came back from Australia for the weather, although I find that very hard to believe. So I think without further ado, we'll move over to you, Raghu, and we'll start your talk.
Thank you. Good evening, and thank you for the kind introduction, Phil. I should also thank Penumbra, along with so many of our industry partners who've not only conducted many webinars in the past, but are committed to conduct quite a few webinars in the future. And for those of you who haven't listened to this, I would direct you to the previous Penumbra webinar, which was at the BSIR ASM a few months back. And Hami and Mohammadi led a fantastic discussion along with Ian McCafferty on the use of Ruby coils in visceral aneurysms. So what I'm planning to do today is to kind of talk to you about our history with Ruby coils, and also look at coil technology in other sites other than visceral aneurysms, which we can obviously take up for discussion. I take you back to 2015, and we've all been there at the dilemma of the final coil. It'll either provide a fantastic embolization, or it will provide you so much grief if it slips out into the hepatic artery. And Alex used to be our representative from Penumbra at that point in time. And she was in the control room trying to, Penumbra had just come into the market in 2014. And she said, oh, why don't you try our soft 3mm, 5cm coil? And she said, if you don't like it, it's a detachable coil, you can take it out. And if it doesn't work, we won't charge you for it. And lo and behold, that coil, as you can see on the left, packed exceedingly well into the last bit of the GDA. Why detachable coils? It provides stability and control. It reduces radiation time, especially if you can position it clearly, and if you don't think that it's working well, you can take it out. Patient compliance is difficult in situations like a GI bleed. And if you have long length coils, even though the cost of the individual coil is high, you can end up using lesser amounts of coils. So let me go back to 2015 when Alex was there as a patient who had surgery for a bleeding DU but continued to bleed. And the interesting thing was the patient had either a celiac stenosis or a near total occlusion. What do you do in this circumstance? So if you look at the picture, you can very clearly see that there is a backfill of the hepatic and splenic circulation from the GDA. So what we did is we looked at the celiac axis and then ended up stenting the celiac axis, and you can see the stump of the GDA very quickly went through the stump of the GDA into the bleeding DU. And as I said, back in 2015, pushable coils were the only microcoils that we were using. We ended up putting this particular coil and then another coil on top, closing off the GDA. And Alex was on in the control room on those very nice days, unlike the present day when you could walk in and spend time along with a case. she said, one, to use a packing coil, and you can see here that a packing coil went in and produced quite a good packing of the back door. So, ladies and gentlemen, the Ruby coil that we've had experience over the last 5 years is a coil which comes with a variety of shapes and sizes. You have the standard and the soft coils. And the important thing about this is, if you think about it, an 035 coil actually has a coil diameter of 021. And the reason that is the case is because it has fibers around it to fit into an 035 catheter. What the Ruby brings is a coil that is almost as big as the 035 coil, which is it's has a diameter of 020, and it can go through a microcatheter. And not only that, it comes in variety of lengths. So what we'll do over the next few minutes is to look at these various coils and see how and where they can be used. Now, this was a patient from last week. Lady with breast cancer, multiple metastasis, PE on tinzaparin injection. She gives herself a tinzaparin injection and unfortunately hits a vessel. So she comes into us, and because of the tinzaparin injection, she's obviously a bit anticoagulated. And I'm sorry that this video is not great, but you can see that there is a bleed coming out of that small artery. So here goes in the first coil, that is a pushable coil, and then in spite of the pushable coil, you can still see that she is bleeding out at that point. And once again, apologies for the poor picture in that case. And the next thing that happened was another pushable coil was placed. So 2 pushable coils, which were fibered, and you can still see the bleeds go ongoing. And the important thing to understand here, that this patient is anticoagulated, and what we want is a mechanical coiling of the particular branch. And what you've seen here is a 2 centimeter or a 2 millimeter, 4 centimeter coil, Ruby coil that goes behind it. It mechanically creates the density that's available to pack this artery and provide hemorrhage control. Another patient, an elderly male with lower GI bleed. We do use 035 coils in the GDA and other situations, but in this particular situation, in the IMA, especially when there is a huge amount of calcium around the IMA origin, you can't take a big catheter in. So here goes the microcatheter, looking out for the lower GI bleed. And if you can see carefully, you can here is a bleed from a small vessel. Taking you to a magged up view, you can clearly see that the patient's bleeding quite extensively from those small vessels coming in. Now, essentially, the question that we are asking ourselves is, can we, with a single coil, pack both the front and the back doors? And a 3 millimeter, 15 centimeter soft coil provides you exactly that. It is quick to deploy, it packs well, and it packs precisely. So that is a very good coil to use. The next point that I'd like to make in this talk is the ability to precisely place the Ruby coil. Now, this is a patient who has a bleed from a GDA, and the bleed is coming off a small branch vessel of the GDA. So obviously you can take the front and the back door of the entire GDA, or you can see whether a particular coil can help you to just take the bleeding vessel, like in this case. A 2 millimeter by 5 centimeter soft Ruby coil helps you pack the particular bleeding vessel that is a branch of the GDA with precision. It's important to make yourself absolutely clear that there are no other smaller branches leading onto it. And that's why in practice, many people would advocate that the entire GDA be taken. But what I'm trying to demonstrate is the fact that you can very, very precisely pack a particular vessel. And another case to make the point, here's a 15-year-old boy who had a sudden onset of left upper quadrant pain after he was coming back from school. You can see the lot of blood within the iliac fossa and an injury to the spleen. Now, we really didn't figure out what was the cause of the injury to the spleen, and we were, in fact, thinking of whether a hemangioma or something like that could be the injury to the spleen. But I did send these images across to Alex Barnacle, our good friend, because this was a pediatric age group. She did raise possibilities of Ehlers-Danlos and other things, but she did say the important thing with this patient is he's bleeding, he needs to be embolized. And if you look carefully, there is increased vascularity there, and the angiogram also demonstrates that there is an area of spleen which shows increased vascularity and requires embolization. Now, the important thing to realize in this situation is, because you don't want to take the entire spleen out, he's a young boy and you want to leave back as much spleen as you can, we would want to take only the pedicles that are supplying that area of increased vascularity. And looking at this very carefully, what the Ruby coil has helped us do, a 3x15 coil, has helped us keep the main artery patent and take only the branch that is coming off the main artery. So precision, once again, playing a key role in order to save this particular bit of splenic artery. And if you look another carefully here at the top end of the spleen, you can see that there is another small branch that is bleeding, a 2 millimeter coil that goes into the branch. And if you keep watching it, a bit of pressure in the branch allows this 2 millimeter soft coil to buckle and go into the branch and pack the branch very well, as you can see on the last bit of that video loop. And thereby, what you get is an excellent demonstration of precision packing using the Ruby coil in the spleen. 6 months down the line, the main splenic artery is patent and can be seen very well, and the splenic injury has healed very well. What about the other coils that we have with the Ruby coil? What about the pod coil? The pod coil is an interesting coil in that it has a front end that tends to anchor itself, and the back end is a softer coil that packs the vessel. And this particular coil will be tested to its limit by Andy, who's going to give us a talk and shows a lot of these coil usages in a pulmonary AVM. So I just, for the sake of completion in this talk, I've just introduced one particular example where you can see the front end of the coil anchoring itself and the back end of the coil nicely packing the particular vessel in question. So that brings us on to a coil called the packing coil, and I love the packing coil. It's a liquid metal. What it does is it completely metallically fills a particular vessel. It's almost like the ice cream filling the ice cream cone. Extremely important for you to give yourself a bit of space for this coil to act and fill. Here's a patient, a young lady, a policewoman who came to us with a fistula between the coronary artery and the pulmonary artery, as you can see there. That particular fistula was causing her breathlessness. So our cardiologist said, you know, we're not very great at coil technology. Can you come and help us coil this particular coronary artery to pulmonary artery fistula? And what we did was to use first a small 2 millimeter coil, and this was a 15 centimeter packing coil. What I'd like to demonstrate is the ability of this coil to pack and pack tightly in the presence of so much of movement. It's very stable. You can actually take the coil back and pack it forward. You have to remember from the previous talk by Mohammadi in the previous lecture that if you don't give it space, the coil tends to push back. But given the space, it tends to pack very well. And when it packs, you can see the mechanical blockage it provides is excellent. There is a small branch by the side of it that is feeding the fistula. which we have successfully coiled. And if you look at the pre and the post images, there is an excellent outcome of coiling this pulmonary artery, a coronary artery to pulmonary artery fistula, and the patient had a good outcome from it. What about detachment? Coil detachment, the back end of the coil is pushed into this detachment handle, and then you just have to click back, and what it does is it just takes that ball forward and detaches the coil. What I've done here is to break the front end of it so that you can see what exactly is happening. What's happening is that this thing is moving backwards, clutches onto the handle, and then pulls the wire backwards for detachment. So the Ruby coil has a huge range of coil size. You know, the standard coils go from 3 millimeter to 40 millimeters, with lengths from 5 centimeters to 60 centimeters. I think what the Ruby coil provides you is procedural success because of precision and packing density. Thank you for your attention.
Thank you very much, Raghu. That was an excellent overview of some of the things you can do with these coils. I particularly liked your splenic case and the selective embolization, preserving bits of the spleen there, and also showing how you can pack that coil into the coronary artery, which I think was a fairly brave place to be coiling. Anyway, what we'll do now is we'll move on to the next talk. And just before we do that, Andrew, just to remind everybody to use the Q&A tab for any questions you've got, and we'll go through those at the end. The more questions you've got, the better, because it makes it much more interesting for everybody else. So we'll now move on to Andrew, who's a consultant interventional radiologist at Queen Elizabeth University Hospital in Glasgow. As you probably gathered, Andrew does a lot of PAVM embolizations, and he's also interested in fenestrated aortic work and fibroid embolization. So we'll move over to you, Andrew. Thank you.
I would like to speak exclusively about the use of embolization techniques to treat pulmonary arteriovenous malformations. And before going on to the nuances of the embolization technique itself, I'd like to just point out that the interventional radiologist here is not just serving as the technician. We've very much got a role to play in both the pre and after care of these patients, which invariably involves MDT discussion with appropriate referring clinicians, and also face-to-face review at dedicated IR clinics. This is mandatory to optimize care of these patients. And also, before moving on to discussing the embolization procedures, I'd like to just remind that the consequences of untreated malformations can be devastating to the patients. These are two patients that we saw here in Glasgow who unfortunately presented with devastating consequences of their untreated shunts. One patient with a brain abscess and another patient with a facet joint infection. The literature quotes that around 10% of patients will have some sort of insult from an untreated malformation. So these lesions are very much worth treating, owing to the devastating consequences that can occur. I'd like to just mention a few salient points through this talk that I think are the highlights and the take-home messages really, and that is that when we're embolizing the pulmonary arterial bed, it's not like dealing with other vascular beds that we treat as interventional radiologists. I think that it's somewhat more unforgiving. And what I mean by that is, well, you have the beating mediastinum, which can offer great instability and really make your procedure technically very challenging. And so you need to have a very reliable embolization platform. And I'll go on to just touch upon that the Penumbra offers confidence when treating lesions that are very close to the beating mediastinum. Instability is a real problem. And also the recanalization rate of treated malformations. This is quoted at about 20%. I'd like to think with the latest technology that we offer, including the Penumbra platform, this percentage I would hope is less than 20%. But the reason why it's so high, that's because there's such a plethora. As you can see in this video here, obviously we have a large shunt at the left lung base, but also there's such a plethora of adjacent vessels that either the CT angiography and the catheter angiography is not resolving that these are indeed already recruited by the nidus. And when you block the main feeding artery, all that happens is that these other vessels then feed the nidus and cause this ongoing recanalization issue, which I think is why we need to be very fastidious at our initial procedure to achieve the optimal embolization procedure. And that, I think, involves proximity to nidus and density. The literature has now shown us that if you're more than 1 centimetre from the nidus itself, you will inevitably have recanalization because you're not close enough. And also, obviously, density as well is crucial. And we want to be achieving this with 1 procedure, at worst 2, because this is ionizing radiation, remember, in a very young patient group invariably. So we want to be optimizing how we treat them. So the Penumbra platform, we will discuss the nuances of through the talk and obviously in the discussion later on. But just to mention at this stage that the main competitor that we use here in Glasgow is the microvascular plug by Medtronic, which is a PTFE covered device that covers a similar range of vessels to the Penumbra platform, and often we find that we use a combination of these 2 different platforms when treating patients with multiple lesions. The mainstay really of the Penumbra platform is, as it states itself, liquid metal with the packing coil. And I think this is true. I think on angiography it does resemble Onyx, liquid embolic agent. The density is so impressive that it's almost liquid-like. And that's the density that's crucial to ensuring that we do not get recanalization in these lung malformations. And obviously as well, with the pod packing coil, the salient feature is this initial anchoring segment that gives you great confidence in knowing that your coil's not going to migrate further than you wish it to when you're treating a malformation. And that obviously is a fantastic feature. And with the Ruby platform, this allows you can use these in isolation in the pulmonary artery when you're treating very small vessels that are too small for the pod platform to be available. And again, that can offer you an adequate embolization procedure just with the Ruby platform, which I'll go on to mention. I was quite interested, just from a interest point of view, just to try and find the oldest archived case that we had here in Glasgow, and that actually dates back to 2008. And you can see from this image here, this is a chest X-ray review of this patient. And you can see that they indeed have a coil placed at their left lung base. And if I mag up there for you, you can see that the density there is not adequate with these first generation coils dating back in 2008. And it was not surprising that this patient suffered recanalization and follow-up CT angiography. These coils weren't even detachable then. So we're very fortunate now to have the latest technologies, for example, Penumbra, where we can achieve excellent embolization. So the technology really has advanced. And indeed, this patient went on to have 4 further angiography embolization procedures to finally stop flow within this nidus. And this just goes to the fact that the technology at that time was nothing as sophisticated as we're now fortunate to have. And again, this picture, I just wanted to again emphasize the reason why this case did recanalize is because we didn't have either that proximity or that density. And you can see that it's the plethora of arteries in the pulmonary bed that's our enemy here, that there's an abundance of vessels that can either be recruited or were already recruited and then hypertrophy and grow once you've occluded the main feeding artery. And it's not surprising that if you don't achieve both density and proximity, you are going to get recanalization. Angulation is obviously a real concern when treating your platform, deciding on your platform to use. And in this case here, you can see there's multiple dogleg angles of the feeding artery down to the nidus at the right medial base there. And wrongly, we chose the microvascular plug platform in this case, and you can see the plug. I'm not sure if it resolves that well, but there's actually a plug sitting here just in front of this coil nest that was then placed behind. And that plug is not sitting adequately. It's even sitting at an angle at one of those dog legs, and we were never going to achieve adequate cessation of flow. So using a plug in that situation was wrong. We were expecting too much, especially owing to the fact that this lesion is very medial and is essentially adjacent to the beating heart, which obviously caused instability or concern with stability at the time of the procedure. And with the plugs, we always place, if you like, a packing coil in inverted commas. This isn't the Penumbra platform we've placed here. This was another detachable coil platform. But you can see that the density there that we've achieved is not adequate. That density of coil nest behind the plug is inadequate. And indeed, this patient on to recanalize, as you can see there, on follow-up CT. Multiple feeding arteries is obviously another consideration. This patient had multiple lesions, and this was a single feeding artery, as you can see, with a very straight line of attack of the feeding artery. And this was suitable for the microvascular plug. This image better shows you the proximal and distal markers of the microvascular plug that in a straight artery were able to get very close to the nidus for an adequate outcome. Obviously, coils could be used in this situation too, but a plug wouldn't be ideal in this situation. This is the same patient with a further lesion in their left lung, and you can see here that there are multiple feeding arteries in this case. There are at least 4 feeding arteries, likely more, as I've touched upon. I don't think we were resolving all the feeding arteries in these complex niduses, and this we managed to achieve excellent packing with the pod platform and the packing coils, and eventually we achieved adequate density and proximity with the Penumbra platform to cause a blockage of that nidus. So again, just to highlight, it's the range that we can cover with the Ruby pod and packing platforms in these situations. We can range this, and in particular with the packing coil, we can now go as low as 5 centimeters up to 60 centimeters, which offers a fantastic range. And I'll go on to mention where the 5 centimeter has got a real advantage, which is the latest small length of packing coil that the Penumbra platform offers. And that is with the beating mediastinum. So you can see here, you can see that I'm not moving this catheter. This is the catheter moving owing to the heart motion. So the beating mediastinum is a real difficulty with these procedures that are abutting the mediastinum, as in this case. And stability, this patient was anxious, obviously they're tachycardic, the conscious sedation is not doing enough to keep them at ease. And this patient made a real difficulty just owing to that catheter motion. But this shows that we did manage to achieve an excellent outcome with the Penumbra platform. And what we've actually done is we've placed the pod 5 coil, and then behind that we placed the packing coil. And initially we took, which is a technical point of interest that I've really now just become aware of, there's a huge difference in the trackability just going from the 15 centimeter to the 30 centimeter packing coil. And the 30 centimeter packing coil was unable to, because of the motion of the mediastinum, we had to go down to the 15 centimeter packing coil to allow adequate tracking of the coil. And indeed, this procedure was technically challenging, and I think now a 5 centimeter packing coil would have been the best choice in this case. So I think when you have lesions that are this close to the mediastinum, the best line of attack is to take 2 or 3 5 centimeter packing coils rather going for an initial 15 or 30 centimeter packing coil. So that's a sort of technical point that I've certainly learned myself. Proximity to nidus, again, just to state, but it's worth emphasising this. This was a case here you can see where we placed this was a case where I used the microvascular plug, and you can see that the plug has been placed far too far from the main nidus, more than 1 centimetre probably. And this was naive, and this patient went on to recanalize, as you can see here. This nicely shows the markers of the microvascular plug, but this is not adequate in terms of proximity to nidus. This patient had another lesion, and I think this lesion we treated with the Penumbra platform, and I think this really nicely shows that you do, in fact, with the packing coil behind the pod coil, you get something that resembles liquid. And it really is a fantastic density that we've managed to achieve here. I'd also like to point out that we shouldn't just accept our first coil configuration. If you're not happy that you've got something that resembles liquid with the packing coil, take 2, 3, 4 goes, retract it back into the microcatheter and achieve the optimal result, because this is going to prevent or minimize recanalization in the long term. And just to finish off, I'd like to just mention that we've always been guided by this 3 millimeter rule with regards treating PVMs. But the joint statement by the British Thoracic Society recently said that there's no longer a 3 millimeter rule, and we should be pursuing all tiny feeding arteries in these lesions. And I think we need to ask ourselves in interventional radiology, as with all procedures we do, that we're doing something because we should rather than because we can. But there's been research now that has actually shown that if you've got an artery, a feeding artery that's less than 1 millimeter, you can still have significant consequence. And there's a paper, a nice paper they quoted, where they showed that in 65 brain abscess patients, which were caused by an untreated PVM, a very high percentage had tiny arteries. So it's worth treating these 1-2 millimeter arteries. And indeed, here's such a case. This, you can see this is a tiny malformation when you see it adjacent to the rib. This was indeed measured at between 1 and 2 millimeters, this artery. And this is just to finish off by emphasizing that this is too small for the pod platform in isolation. And what we actually used here was the Ruby Softs independently. And I think the Ruby Soft platform can be used on its own to achieve, as you can see here, an adequate proximity and density. And just a final thought to go into the discussion. I think this we can bring into the discussion to discuss further, and that is, how should we treat these large niduses with multiple feeding arteries? And this was such a case that we had here in Glasgow, and this is the Penumbra platform, which has achieved density and proximity that you would accept, and there was no feeding of the nidus at the time of the final angiography, but follow-up CT did indeed confirm significant recanalization. So I just wonder, should we be packing the nidus in such cases? Thank you for listening.
Very much, Andrew. Some fascinating stuff there, some really good use of this technology as well. We've got quite a few questions come in. So actually, why don't we just start with that first problem you posed there at the end, Andrew, with that large nidus. Maybe we'll discuss that briefly before we go on to the questions from the audience.
Mm-hmm. Yeah, so it's actually 3 cases now in Glasgow we have akin to that one, where you've got a relatively large nidus. And I think the larger the nidus, the more likely it is to be complex, isn't it? You have more than one feeding artery. And I definitely think you don't always resolve the number of arteries with CT angiography. I think that it underplays it, and that there are more involved that you're just not resolving. And I think going forward, given there's now 3 cases that we have of similar to that large nidus, multiple arteries, I think we probably should be packing the actual nidus. I'd be interested to know if you've experienced, Raghu, yourself of packing niduses and PVMs.
Yes, I mean, we do quite a lot of PVMs, and my colleague Graham Robinson has a special interest in that. You'd have heard. We do pack the nidus, but I would suggest that in a similar situations like yours, we would come back to it a bit quicker on a follow-up, just to see if there's been a hypertrophy of any other artery that requires treatment. Mm-hmm. But I liked your end result. That was brilliant.
Yeah, I think obviously you want to be doing one procedure, don't you? That's quite something that's useful to stress, isn't it? Because most of our patients are in their 20s, 30s when they're getting detected. I think you want to be getting a one procedure to sort of, to achieve the optimal result. So I think the Penumbra platform could certainly offer that, couldn't it? With the range of coils that they have, that you could easily pack large niduses like that last case without too much ado. Yeah, so I think it's probably sensible. Obviously you can then pack as many feeding arteries as you can see as well. I mean, you can pack the nidus and the arteries, can't you? But I think that'd probably be the optimal result in these cases.
And what's your opinion about the pod coil for these kind of high flow arteriovenous malformations?
Yes, as you touched upon probably more than I did, that it's that initial anchoring, isn't it, that's fantastic. It is. It offers you that confidence, especially when you've got, maybe a large outflow feeding vein, a large draining vein, sorry, and you've got a large nidus. You do have that concern, don't you, that you're not going to accidentally cause an iatrogenic coil embolus, which is a real risk. And I think the range that you have that confidence, don't you, that you're not going to have that problem.
Yeah, I think what people used to previously do was to go into a side branch and anchor the first coil, because you were afraid that this coil would fly away into the systemic circulation.
Absolutely, yes.
And what the pod offers you is that ability to anchor it in the main vessel and then pack it with the soft coil behind, isn't it?
Yeah.
I think that takes us quite nicely on to one of the questions. A few people have been wondering about this, who are maybe not familiar with the system. They were asking about when would you pick a pod versus a ruby versus a packing coil? I think you've partially answered that question already.
Yeah, I mean, certainly going for the pod, I mean, it doesn't have to necessarily just be high flowing. I mean, the pod certainly if it is high flowing, you definitely go for the pod. But I think it just offers that you just place it exactly where you want it. It's not going to meander where you don't want it to go. So I think going straight with the packing coil, I'm not in the habit of doing that. Because that's the liquid component we're talking about. I think that just offers that fantastic back door where it just bolts and braces, isn't it? The liquid component to it. But I've used now the Ruby Soft, so treating 1 and 2 millimeter arteries, which I've now done a good few of, given that's now what we're being told to treat. I think the Ruby Soft does well on its own. I've not had any real problems with it. I think, obviously, if you've got a 1 millimeter feeding artery, it's not going to be a high flow state, is it? It's going to be a low flow shunt, invariably. So you're not so concerned. You're not going to have a big, large draining vein, and invariably you're going to have a very small nidus, aren't you? So I think the Ruby Soft is fine for those smaller malformations, but definitely take a pod for these bigger, high flow malformations where there is always that underlying risk of mischief of the coil not going where you want it to go.
Do you find once you've taken out one feeding vessel, other ones become more apparent in these situations?
Oh, yeah, even at the time of initial angiography, yes. I think even, I'm sure you found that too, Raghu. I do find that you take the pigtail catheter back into the main pulmonary trunk, you do another angiography, and you go, oh, look, where'd that come from? And you'll go back and look at the CT, and it's not there. The CT hasn't resolved it. It's very interesting, and that's definitely what I've come to realise over the last year or two, is that unlike other vascular beds, I think I maybe touched upon that in the talk, I think the pulmonary arteries do behave differently. Obviously, there's more, the density of pulmonary arteries in such an area is enormous, isn't it, relative to the upper GI tract or the lower GI tract, whatever. But I think that just owes to the fact that there are so many arteries that can be involved, which is why it's a slightly different beast that we're embolizing, I think. You need to be a bit more diligent, I think, with your coiling.
And how would you choose the size of the coils you're using, Andrew, and then Raghu? So Andrew for pulmonary arteries, Raghu for visceral vessels, and also the size of visceral aneurysms you treat, Raghu. Do you
want to go first, Raghu? Or?
No, you go for it.
So, I mean, obviously it's all CT workup, isn't it? All these patients with a CT. I'm even finding with COVID, it's caused a real problem that we're now treating 1 or 2 patients again over the last few weeks. And because of COVID, the time interval of the CT can be quite long. It can be 2 years 2.5, 3 years. So that's caused a bit of a conundrum, because obviously you want these malformations can grow to a greater or lesser extent, and no two patients behave the same. But we are relying upon the sort of 2-3-year-old CT, and that has been reliable. Just to point that out, I think you don't need to be getting up-to-date CT imaging. Why subject the patient to more ionizing radiation? So that's something that we've learned, that you can trust the 3-year CT. And then the pods are it's very straightforward about how you size up. You know, the pod 5 to treat an artery 5 to 6 millimeters, pod 6, you know, pod 3 all the way up. So it's all measured to the artery, the feeding artery. And then obviously the packing coil behind hasn't got a set diameter. It's just a length then that comes into play. And the main thing I'd like to stress about the packing coil is not so much, it's also not the diameter, because it conforms to the diameter of the vessel, but it's more, this is where the length is crucial. And I think so they've now just introduced the 5 centimeter length, whereas before they had the 15, 45, 60. And I've found that from that case I showed with the beating mediastinum, that the 30 centimeter and the 15 centimeter coils, just common sense, physics dictated that it was incredibly difficult to confidently place the coil all where we wanted. But I had a case where we didn't have the 5 available, but we took the 15, and the 15 behaved very well. So we ended up placing 2 15s as opposed to 130 coil, if that makes sense. And I think that's how you should approach these cases when you do have a concern about stability owing to motion of the mediastinum.
Yeah, I think, Phil, from a peripheral perspective, I mean, Andy's given a lot of information on the pulmonary circulation. So coming back to that question on how do you would you use a soft coil or a pod coil or a packing coil? So Penumbra has now made that important correction, if you may. They used to call it the pod packing coil and the packing coil. And then that used to confuse people. So they've now decided to say you have the Ruby coil, of which you have the standard and the soft. And then you have the pod coil, which has the anchoring coil in the front and the soft coil behind. And then you have the packing coil, which just has the soft coil. So coming back to that question, so if you're in, let's say, a GI bleed or something like that, so like Andy said, we would choose a nice long soft coil. What it's doing is a soft coil has the ability to start coiling in the artery and then pack from behind. And somebody I noticed have asked the question, how do you size the coil? Phil will agree with me, you kind of eyeball it and size the coil. The IFU states that your coil size should be 10% more than the size of the artery. But it's a detachable coil. Let's say you took a 2 millimeter coil and that was too small. You can always put it back and then go with a 3 millimeter coil and put the other coil within this to get your coil density packing. So with the pod, you generally in the peripheral circulation, you don't jump to the pod. A, it's an expensive coil. B, it has that anchoring bit and the back end. So you want to use it in specific situations. Like, Andy said, an AV malformation, or if you want to say that you don't have a baffle in front, I want to create a baffle and then put the packing coil behind. The pod is nothing but a stiff coil at the front, which gives you the baffle, and the packing coil behind, which packs. Now, coming to the packing coil, you generally use the packing coil after you put a coil in front, like we did with the coronary to pulmonary artery fistula. Think of the packing coil as liquid metal. Think of it either as if you have that ice cream that I was showing, or think of it like spaghetti. And as long as you have a container to hold it and you put the spaghetti in, it'll pack nicely. So you want something in front. So you start with a soft coil, and then you decide, okay, I'll put a soft coil. I have a long vessel to pack. Then you can say, I'll take a 15 millimeter packing coil and then nicely pack behind it. And you have to give it space for it to pack in.
I think the other thing to remember about all these coils, with them being detachable, of course, you get more than one go at it, don't you, Raghu? If it doesn't sit right, you can just pull it back, push it back in again. You can also use a bit of the coil as a catheter to work your catheter, as a guide wire to sort of pull your catheter forwards into the bit you're trying to pack. You can work the two together, can't you, backwards and forwards?
Absolutely. And also, there might be some, if you ask Penumbra, and maybe they will come into me and after the session and say, hey, you shouldn't have said this, but the coil, the IFU states that you need to have a fluid flush going continuously with it, right? And we do that if you have a long coil, because that gives you the ability to put the coil in, pack, bring it back, and all those kind of things. GI bleed. Patient is 40 systolic or 50 systolic. You just want to, you got your catheter in place. You just want to bung it up with a coil. Practically on the floor, you just take the coil and then push it through, and it works very well. Even without that flush, sometimes you can even pull it back and then reinsert it. I've done it. We all have done it, and it works well.
Yeah, absolutely. Now, someone's asking along that line. They've said, do you always use the Penumbra lantern catheter, which is their microcatheter, or do you use different sorts of microcatheters? And he's then said, and along the same vein, I guess he might mean artery as well, the lantern needs an 038 diagnostic catheter, and which are your go-to 038 diagnostic catheters to use with the lantern?
Okay, I'll go first. I think I have to be honest here. We use the pro-grade catheter. And the reason we use the pro-grade catheter is it comes with the wire attached, and you can quickly put the catheter with the wire in front. You choose whichever catheter you want to get into depending on where you're going. Supposing you are in the renal artery, you might want to choose an RDC or something like that. If you're inside the GDA, you may want to use a C2 or a SIM1 to get into the celiac axis and position it well. The important thing I would say for some of the juniors who are asking this question is, and both of you will agree, is you need a stable access, because when you're pushing a coil forward, there is a certain amount of kickback happening. And if you don't have a stable access and you have just a slippy catheter, you don't have a long enough sheath, and you don't have a stable access, the whole thing will kick back. So important thing for those registrars who kind of in the meeting is you prefer to have a stable non-slippy catheter in a stable position, and then a microcatheter through it. Any catheter that would take a microcatheter is fine. We tend to use some of the tempo catheters, or SIM catheters, or SOS2s and stuff like that.
Yeah, we use the same. I mean, having good stable access is absolutely key. We use ProGrates a lot as well, though I don't have much experience with the Penumbra system. But one thing I will say about the ProGrate, I don't like the 2.7 that comes with the wire, because you can't move the torque device on the end of it. It's fixed, as I always like to move it and try and do it with one hand. So that's right. I use a different ProGrate to that one.
I should mention I have used the lantern catheter, though it's not a go-to catheter. It's 150 centimeters. The advantage of the lantern catheter, it comes in various shapes, and it doesn't come with a wire by itself. I tend to use a Synchro 14, which is a neuro wire, which is very nice. Especially if I give you a scenario, if you're doing a type 2 endoleak embolization, you're going through the SMA around the corners into the IMA. You need a long catheter, and I found that the lantern catheters work very well with the Synchro 14 wire.
Yeah, and you also need a wire that torques well, don't you? So you can steer it. So someone else was asking, probably aimed at you, Raghu, mainly, what are the sizes of asymptomatic abdominal visceral aneurysms you would consider treating? When would you treat? When would you watch?
It's a difficult question, as you know, Phil. What we tend to do in our own practice is anything that's more than 2 centimeters, we are concerned. But it depends on the patient. And Andy said a very, very interesting thing. We're not technicians. We're clinicians, clinical radiology. So if you have a young female patient who might become pregnant, you would treat that patient slightly differently to the 82-year-old person who has the same size aneurysm, because we know that the rupture risk is higher in younger patients who are, going through pregnancy and other things. So I would say if you have a less than 2 centimeter aneurysm, if there's some calcification around it, we would wait and watch, and we would do a short interval CT in 6 months or a year. And then if that aneurysm is demonstrating growth, then that's when it goes back to the multidisciplinary team meeting in order to treat. Whereas younger female patients who can become pregnant, we're a bit more aggressive. So 2 centimeter is your magic number.
Yeah, so nothing's changed in the last 20 years, because that's been the sort of classic teaching for many, many years. Andrew, would you agree with that?
No, I mean, they all go through the vascular MDT, don't they? And sometimes it depends who's at the meeting, yeah. But but I think 2 centimeters is a good rule of thumb, I think.
Yeah.
And just before I forget, I'd like to just something you said there, Phil, about which I think is really a good point to stress again, is using, when you put the coil out, you were saying how you can sometimes use that as a guide wire almost to then, because your prograde or your lantern, whatever and I'd like to say, I don't think it matters really if you have a prograde or a lantern. I think, there's not a lot to choose between. So I wouldn't get too hung up for people who are asking which microcatheter should I use. And I think the 038 catheter that you're putting the lantern or the prograde through as well isn't a huge deal, is it? I mean, it tracks through most 038 catheters. But just to say that, as you've said, it's such a good function that of the detachable platform is that when your prograde kicks back, say, out of the branch artery you want to be in, no matter where you are in the body, not just talking about PVMs, you can then just nicely use the coil. If you've got, a second operator is mandatory as well for these, isn't it? You need to have somebody who's experienced beside you it's a 2-man job where you're then just you're getting the tension right, aren't you, on the coil itself, and you're basically turning the coil into a wire.
Yeah.
So it's a really nice trick that you can definitely use.
Yeah, I do this a lot when you're trying to pack a coil. Basically, use your right hand to pull back on the coil with attached, as you're using your left hand to advance the catheter further into the aneurysm, and then you can push the coil forward again. Mm-hmm. You can actually do it with 2 hands. You don't need an extra operator necessarily.
Oh, see, I'm maybe not skilled enough. That's fine.
No, being an octopus helps as well. Having very long arms actually also.
Oh, that is, yeah.
A high ape index, as they call it.
Yeah, and I think there was one question that's come out in the chat section, which I was surprised, which adds on to what Andy is saying. Is a question which says, which inner diameter microcatheter do you need for this coil? So it doesn't matter whether you're using a lantern, prograde, whatever it is. The coil itself is an O2O coil. So you need a microcatheter that is big enough to accept that coil.
One thing I'm interested in knowing is do either of you have much experience with Onyx? And I mean, some of these scenarios, would you use Onyx to follow on from one of your coils? It's something I do sometimes.
We've kind of went off Onyx a wee bit, if that's the way to put it. Yeah. We used to use it a lot for EVAR endoleaks. That was our mainstay. And sometimes for varicose bleeding in sort of, TIPS type scenarios, your patient with large shunts, bleeding shunts, we were using that. But we're definitely using it less than we used to. Partly because we weren't getting a great outcome, I must admit. Obviously, we could speak for hours on endoleaks, couldn't we? That's can't be covered. But we were fine. We weren't necessarily getting the outcome we wanted with Onyx and the relative cost. And I think that mirrored by the fact that the technology has come along now, hasn't it? The coils now are fantastic, and you've essentially got a coil here that's like liquid, isn't it? I mean, to me, it's like Onyx and angiography. You can't tell the difference almost. But I dare say it's still got a place on Onyx. Yeah. I think it's still got its place in treating variceal hemorrhage, for example. It could still be if you're not close to the culprit where you want to be. And I think for iliolumbar endoleaks as well, I think Onyx still has a route to play there, because obviously you can get that cast more distally and you can get your microcatheter. And the coils are limited by how far you can get your microcatheter, aren't they?
Yeah, I think it's useful.
Onyx still has its role, but I think less so in our hands in Glasgow anyway.
Okay, that's interesting. Raghu?
Yeah, we use, like Andy said, we use Onyx with endoleaks, and what you're doing is you're using a combination of coils and onyx. You're putting a framing coil that'll kind of almost hold the onyx within the lake. And once you start injecting the onyx into the lake, and then it tends to go out into the various crevices within that lake to fill it up. So those are the situations that we mostly use onyx treatment of endoleads, along with coils. So it's a combination.
Yeah, we use it with acute bleeds as well. It's quite good to get somewhere, as you both said, where you can't get your microcatheter to, you can just push it forward. So there's one other question regarding pediatric embolization. They were asking why use coils and not temporary embolic agents?
I think the question that's probably being asked is why not gel foam is the question, isn't it? I mean, the reason is, shooting gel foam through a microcatheter is not that easy. It just keeps clogging up. And the other thing, if you remember my presentation, we were, wanting to preserve the main splenic artery and try and just embolize that bit of it. And if you looked at those pictures, I mean, the Penumbra gave us a fantastic result at the end of it. So it brings across a very interesting question, actually, which is a kind of a side question, which is recanalization after coiling. Coiling, the way the question is being asked is a completely permanent embolic material. That's not necessarily the case. So there is quite a lot of collateral circulation in the spleen, and sometimes coils tend to recanalize and flow through. And when you looked at my follow-up ultrasound images, because he's young, we didn't do a CT, we had very good splenic tissue. There was no major infarct within the spleen. It was quite a good outcome.
I wondered if he'd been in a fight on the way home from school, actually, Raghu.
You might have hit the nail on the head, though refuses and denies completely.
Yeah.
Which is why we sought some help to asking for some of the weird and wonderful condition that Great Ormond Street might have seen in that case.
I'm sure they've seen plenty of fights at Great Ormond Street.
Much more than Hull, Phil. Probably it's common in Newcastle.
Okay, I think we're probably about ready to wrap things up now, unless there's any more burning questions or anything Raghu or Andrew would like to add to this discussion.
I think I would just sum it up, Phil, to say that, I'll ask myself a question. There's a question about fibered versus non-fibered. Yeah. Penumbra is a non-fibered coil, and then fibered coil. And there's no clear-cut evidence. In fact, Scott Terratola has done a review article in one of the journals, recent journals, where they've looked at embolization with fibered and non-fibered. And the only thing that the fibered coils did was the number of coil usage was 1/3 the amount as compared to the non-fibered coils. And the advantage that Penumbra gives you is because it's a big coil, it's O2, it's almost like a 035 coil, the ability to mechanically pack and the lengths and sizes that you get, this question of having to use lesser number of fibered coils, you can use one Penumbra coil and just achieve the same length because the range is extensive. I think the extensive range comes from the fact that Penumbra used to be a manufacturer of coils for intracranial aneurysms, and they brought that technology to the rest of the body. So a huge range of coils. And once you start using them, it almost becomes a go-to coil to you.
Okay, thank you. Andrew, any further comments?
I think maybe my closing remark would just be, remember that with these detachable coils, don't accept, I've said this in the talk, but just to re-emphasize again, don't accept your first position. I mean, I think there's this habit, don't we, that we just think, oh, that'll do, and move on. And I accept as well, though, you don't have infinite goes. That's also true, that you do get fatigue. I mean, and I will say that Penumbra's maybe not the best in that capacity. I know other detachable coils also that problem. We have had problems in the past with other platforms where the system fatigues, and eventually you'll get to a point where it's not detachable. I think most people have probably been in that situation, but That's maybe if you've been overzealous, but I think just to emphasize that Penumbra I've found is very forgiving. You can have multiple, bring it back into my catheter 5, 6, 7 times to achieve what you want to achieve, and don't be scared to do that. Would be my kind of closing remark.
Yeah, absolutely, and I agree. Agree with that. With all detachable coils, just keep going until you get the result you want. So I think with that, I'll wrap this all up. So thank you both very much. You both obviously got a huge amount of experience using this technology, and you've shared some fascinating cases with us there. And I think we've had some good discussion, and hopefully you've clarified things in people's minds as to how you go about using this equipment. So I'd also like to thank Penumbra very much for sponsoring this webinar, and also Scott and Ruth for helping to facilitate it. Thank you very much.
Thank you.